The problem we're now facing is that younger and younger patients are getting it. And that's why the screening colonoscopy age dropped from 50 years old to 45. But now even younger than 45 are getting these problems. Now, with a combination of chemotherapy, radiation, and surgery, we have up to 30% of the patients that receiving chemotherapy and radiation, including genetic and hormonal therapy, will actually become cancer-free without surgery. So there is some statistics that said over 90% of the population in the United States is constipated.
Welcome to Autoimmune Alchemy, where we turn complex autoimmune science into clear, practical steps you can use to feel better and take control of your health. Hello, everyone. Here we are at Autoimmune Alchemy, blending science with soul. I'm your host, Dr. Molsa Mandela. I'm so excited to have my dear friend, Dr. Amir Esparza, who is a double board physician in surgery and colorectal surgery. He has a passionate desire to really help humanitarianism. He has research in minimally invasive colorectal surgery and robotic surgery. He's a physician at City of Hope, and I'm so glad because he has holistic approaches and happy to have him here. So thank you, Dr. Esparza. Glad to have you.
Thank you. Thank you so much for inviting me, Melissa. This is great that you're doing this to educate the community, and I'm happy to be part of it.
Thank you. And I know just hot off the press, we see that colorectal cancer screening is improving. However, we do see it in younger ages more and more, and sometimes the media actually portrays it a little bit more. But just want to know, are those stats changing, and why do you think there's more colon cancer, colorectal cancers these days?
Yeah, no, the problem we're now facing is that younger and younger patients are getting it. We kind of saw the trend over the last 10 to 15 years. And that's why the screening colonoscopy age dropped from 50 years old to 45. But now even younger than 45 are getting these problems. And the main issue is that if you are one of the patients who start getting symptoms, a lot of them are being disregarded. So when these young patients come to see us, unfortunately, they're aggressive, large tumors. But and the reason why it's happening, and multifactorial, environmental factors, the food or stress or daily living and family and exposure. So it's just multifactorial, but unfortunately it is in the rise now, becoming now the number one cause of death in younger patients, in younger adults.
Right. It's so sad to see the statistics. They say by 2030, you might see up to 20% of people, starting 50 and younger, 45 and younger, being diagnosed with colorectal cancer. And what are some of those first initial signs, because sometimes people may just think, oh, it's just constipation. Oh, it's just, maybe it's a hemorrhoid. What are the early signs, if there are any, for colorectal cancer?
Yeah, though that's a great question. So the people who end up having symptoms, which is, probably 50%, or sometimes in some cases less than that, which means sometimes the majority of them don't have any symptoms. But if you're one of the patients who have symptoms, we really pay a lot of attention to rectal bleed, abdominal pain, change of the shape of the stools, weight loss, undesired weight loss associated with low appetite, rectal pain. So those are the things that we have to really make sure we bring up, especially if you have family history of colon cancer.
Right. I know oftentimes we learn in medical school, maybe the stools turn a little thinner, but patients may not be able to, don't even look at their poop. Unfortunately, they're not really examining it. They don't realize that there is a change. And what do you see in your practice? When is it diagnosed and caught? Is it usually stage 3 or 4? Or is there a thing, are people coming early on, stage 1 and 2? What does the statistics look like when they actually get the diagnosis?
So less than 20% of the people are diagnosed during the screening colonoscopy.
Wow.
The majority of them are based on symptoms. So the problem is that if we are waiting for the symptoms, a lot of the time is advanced disease. Symptoms normally appear in the colon. As you know, it's a long tube. It's approximately 3 feet long. It goes from the right lower side of your belly. It crosses the entire belly. Then you go to the left side and then gets into the pelvis, and it becomes the rectum, and then the anus, and then, is the exit. So depending on where the tumor is, normally tumors that are on the left side will cause bleeding. Normally tumors who are in the rectum will cause change in the shape of the stool. But tumors who are on the right side, a lot of the times don't give any symptoms. The symptoms that they will give are delayed. As I said, abdominal pain, weight loss, fatigue. To get to that point, it means that the tumor actually grew quite a bit. Fortunately, we have a lot in our arsenal to take care of it. And the goal as a surgeon, when patients come into my hands, is curative. So we're going for cure.
Yes. And let's talk about that, because sometimes people don't realize that, that there is a potential for cure. And they think they hear the word colon cancer, they think it's the end of the road. And what are the possibilities now with research and technology for treatment?
Oh, it's such an amazing and uplifting news. The patients who are, the rate of diagnosis of colon cancer is increasing, but also the rate of curing, it's increasing. We have several modalities now. There has been a lot of research on learning about the genetic composition of the tumor. Not every tumor is different from each other, but now we can differentiate and classify them based on the chromosome analysis, based on genetic testing, where we can have more targeted chemotherapy, where the response for it is great. One of the examples, which is very exciting now, rectal cancer used to be a very aggressive, big surgery in the past, where a lot of the times there was no space for reconstruction, and patients needed to have an ostomy bag forever, and the outcomes were not good. Now, with a combination of chemotherapy, radiation, and surgery, we have up to 30% of the patients that receiving chemotherapy and radiation, chemotherapy including genetic and hormonal therapy, will actually become cancer-free without surgery, which is a great news. When that happens, they come down to surveillance, and we call it watch and wait. You're just looking at them every 3 months. Watch and wait. If there is any suspicion of coming back, at that point we're prepared to remove it with surgery. But thankfully now with the technology, that's what I do. With robotic surgery, very rarely you have to give a permanent colostomy.
Well, that's very, very helpful, because before we would see that often, just full on partial or full colectomies, and just because of a large mass. And now it's great to see that. And what have you seen that would help after the surgery, after they get diagnosed, after they got treated? What helps with remission rates?
So obviously, we call it R0 resection, means that we remove every visible and invisible microscopic tumor with negative margins. So normally when we go after the tumor, we remove the part of the organ and the associated lymph nodes. Normally colon and rectal cancer starts in the lumen, in the inside of the colon or the rectum, and it grows through the walls, and then it goes to the lymph nodes. So we try to remove all of that. So that's a really, really good and important first step, have an R0 resection. After that, our main goal is to reconstruct, to put it back together. And with the technology we're having now, it's way more feasible to do that.
That's amazing. And, when people are just trying to understand the risks for colon cancer, and they're asking themselves when they should get screened. I know this may seem like a Simple question, but sometimes people are confused of what kind of family history matters and what doesn't. Can you explain that?
Absolutely. That's a great question. As of right now, every patient who is asymptomatic without family history of colon cancer needs to start screening at 45 years old, men and women. In other words, if you're completely healthy, you don't have any problem, and you don't have any family history, you need to start your screening at 45 years old. Now, when we talk about family history, the family history we really pay attention to is the first degree family member, meaning parents or siblings or kids, the first degree family member. So depending of their diagnosis age, the colonoscopy will be modified. The date of the colonoscopy will be modified. Normally, it's 10 years prior to the family member's diagnosis. So if a family member got diagnosed when they were 50, they need to get a colonoscopy at 40. We are talking about patients who don't have any symptoms. Now, if you're a 27-year-old person and you start having rectal bleed, you need to pay attention to it. If you are a 29-year-old and you have started rectal bleed, you need to pay attention to it. Go to the primary. I understand that over 90% of the time is related to benign issues like hemorrhoids or small tears, which are very easy to differentiate. So that moment, the primary doctor, Dr. Mundala, Melissa, you can, evaluate plus or minus exam, making sure they are not constipated, making sure they're not pushing, not straining, having a high fiber diet. But if the problem continues, it needs to be watched closely. If it continues, definitely they will need to get seen. And that is not called screening anymore. Screening only is for patients who are asymptomatic. Patients who have symptoms, like, for example, rectal bleed, they become a diagnostic. So then we tend to do a colonoscopy for that.
That's really important because I think oftentimes people don't realize that those symptoms cannot be ignored and it's not always treated by lifestyle. There might be something else. And I know in the autoimmune community, they may have IBD or ulcerative colitis, Crohn's, and we have patients with previous history of cancer. What are the risk factors for that in the autoimmune world? Have you seen that overlap in terms of increased risk of either the rectal bleeding because of cancer or because of some type of autoimmunity?
So rectal bleed, as we were talking about, the majority of the time is due to benign disease. And the most common cause is hemorrhoids, but not always is hemorrhoids. So a lot of my patients come walk into the door and say, "Doctor, I want you to see me because I have hemorrhoids." First of all, we all have hemorrhoids. We are born with hemorrhoids. They are part of our anatomy, part of our physiology. We need them to help us with our continence, to be continent, help us to differentiate between liquid or gas. It's an amazing structure of an anatomy. Obviously, if you treat it poorly, like sitting in the toilet for too long, playing with your phone or staying there till they grow and then they can bleed. So in terms of bleeding, that's one of the causes. But then there's multiple other causes. In terms of the part, autoimmune part that we were talking about, that's when we talk about IBD. So inflammatory bowel disease, which encompasses ulcerative colitis and Crohn's disease, one of the signs that can happen is rectal bleed as well. Okay, so that's why it's so important. There's no way for us to know if it's either one, or cancer, or just hemorrhoids or a fissure, without taking a look inside. And the most accurate way to do that is doing a colonoscopy.
Right, and let's talk about that colon real quick because, a lot of people go into the ER because of diverticulitis that they've been having for years, and suddenly it becomes inflamed. And what if a common question that we always get is, how do you prevent this? Does it ever go away? how do you manage someone with diverticulitis?
Yeah, great question. Yeah, so diverticulitis or diverticular disease is one of the most common colonic issues that we have in the United States. And is interesting, very rare in other countries like in the Mediterranean. And it is very clearly associated with the type of foods we have. So diverticular disease, just for our listeners that want to know a little more about it, basically with chronic constipation, with pushing, straining, and lack of fiber, the wall of the colon that normally is smooth with like a really, really nice smooth tube, develop some lumps or pockets, they call it. So it creates such a tremendous amount of pressure inside that tube that it delivers it pressure through the weakest area and becomes like a little pocket. Very similar to a tire, like a truck tire or your bike tire. If you go hit it the side of the sidewalk, you can develop those pockets or lumps that you can see from the outside. You can still ride a bike, you can still drive your car. The chances of it bursting is higher than if you had a complete normal tire. So the reason why it's so common here, and if there is one single word that I can deliver to our listeners, is fiber. I'm a big proponent of fiber. All my family members and my wife really, when we were just dating many years ago, says, "Oh, we should call you Dr. Fiber. You only talk about fiber all the time." And, obviously that was over 10 years ago. Now everything is kind of like normal to hear. Like in almost every product that we buy, it says fiber. Because the type of diet that we were exposed, especially fast food diet, has a minimal amount of fiber that becomes hard for our body to digest, and it doesn't create a good microbiome, and is highly associated with chronic constipation, and that's how everything starts. Now, as a colorectal surgeon, we see the patients who have recurrent diverticulitis. So this diverticular disease, where there are these pockets, 10 to 20% of the patients have the luck or bad luck for it to burst. So they burst, and the bacteria that is inside the tube goes outside that little defect that it has created because it has bursted, and the bacteria escapes and creates a significant amount of pain. Normally it's in the left lower side of your abdomen. We call it the left lower quadrant, associated with fevers, chills, nausea, just feeling sick. It does depend of the amount of bacteria that goes outside the tube of the lumen. If it's a little bit, you'll have something that will probably go away, just resting your bowels, not eating. But if it's significant, you might develop an abscess or pus, or you can have even a perforation that will need a emergent surgery. So I do see patients who come in with recurrent diverticulitis, with these issues that come. And unfortunately, these pockets that were created decades ago don't go away. They will not go away. You can prevent further episodes adjusting your diet, making sure you don't get constipated, increasing the fiber. But sometimes, unfortunately, it's too late for it. And I have patients that even with soft diet who have the trigger. And then, those are candidates for surgery. Again, thankfully, now with the new technology, the majority of the patients who have the surgery, it's a surgery that it can be done robotically, where we remove that piece of the intestine that has those pockets, we put it back together, and we send them home. This surgery, before the robotic system and minimally invasive surgery was available, needed to stay in the hospital 7 to 10 days. Now they normally stay 1 to 2 days. So the recovery is pretty fast. And because we do in tiny little small holes, the pain is minimal from the recovery, but then obviously the chance of it coming back is very, very low.
Yes, I think that's very hopeful. And because I take diverticulitis very seriously because it's, they go to the ER and then it's very lifestyle related. I know that a lot of patients not only have low fiber, but sometimes they have high alcohol use. And that combination is just inflammatory and they tend to get repetitive episodes. And then sometimes I don't know if you see this, there's maybe an old way of thinking or maybe still trying to understand this. Before everyone was afraid of seeds and nuts being stuck in the colon and these diverticula. But now, all of that is rich in omega-3 and fiber and protein. So what is, the research, your understanding of it? And do you still find that when you do these procedures, stuff what kind of foods do you find stuck in their diverticula?
No, it's a old-fashioned misconception. There is no single seed or fruit or piece of food that can that does get stuck and directly is the cause of the diverticulitis. That used to be the thought about it, and old-fashioned physicians and providers used to say, "Don't stay away from that. It has not been proved." And it's a very easy way to explain why. When we do colonoscopies for screening, there is a very high percentage of patients who have diverticular disease, especially if you're over 60 years old. Really high. And then you ask them, have you ever had any issues with pain or with fevers or chills? No, I never heard of that, doctor. How many pockets do I have? It doesn't really matter. You can have 1 or 100. We don't know. We cannot predict who's going to have the issue. And these patients who are on that day of the colonoscopy told that you have diverticular disease, these are the patients who for decades were having any type of food, any type of seeds. They never really have the trigger of it. As I said, less than 20% of the time, patients who have diverticular disease will have a diverticular attack. And the majority of patients who have one diverticular episode or flare-up don't have it anymore. So, and it is not clearly related to the pockets getting obstructed. It's just a combination of multiple factors, as you said, and inflammatory foods or alcohol, the lack of fiber, and sometimes it could be also a genetic predisposition from family and background.
Right, so important because often people don't realize till they get these colonoscopies and they've been living with it.
Yeah.
And they don't realize that. And are there early signs of diverticular disease? Like maybe someone's in their 20s or 30s and or 40s and they are having some symptoms of it, but they don't realize until either their colonoscopy or when they have an episode and sent to the ER.
Yeah, no, thankfully it's uncommon for younger patients. It takes many years to develop diverticular disease, but it's not unseen. So one of the high risk factors is obesity. So on experience that we have, a lot of the patients who present with diverticulitis and are very young are majority of the time overweight. So that's a really important risk factor. And normally, for men, it's a little bit more easier to target the diverticular pain because it's in the left lower side. There's not really other thing that can cause that type of pain. So if you're having that type of issue, especially after you eat, and discomfort, it doesn't go away, and then it takes a day or so to go away, those are the signs. For women, we have our ovaries, it can be cysts, you have all the gynecological organs there. They can sometimes be, or is it a period? It's difficult to differentiate, but in those cases where, as you know, you have a lot of pain and fevers and chills, the most accurate test at that moment is a CT scan. Colonoscopy, as we say, will find the pockets, but those pockets may or may not be the cause of the pain.
Very important. And what other diseases happen in the colon if it's motility or constipation? What are other conditions that people need to be aware of?
Oh my God, yes. So the colon, it's I'm excited that I have and happy that I picked this pathway in medicine. Now there is so much research on the microbiome. So we have over 3-4 pounds of bacteria living with us, and the bacteria lives in our colon, and they have a direct impact into our gut brain connection. So to have everything in a summary, we definitely are what we eat. We feed our bacteria, or we need our bacteria. It's part of our immune system because we eat bacteria every day. So our immune system, you have a strong flora or a strong microbiome, you can be healthy. At the same time, if you feed the wrong bacteria, for example, with high sugar diet, with low fiber diet, with ultra processed food, you're changing your whole habitat of this microbiome, and it really is connected with a lot of things that we're finding out. Connected with our mood, connected with our sleep, connected with our energy levels, connected with our sugar levels, with our blood pressure, with our cholesterol, with our heart. It's so incredible now that we have found that so important area of our body that we really, really have to take care of it. It is one of the main engines of our system.
Yeah, I love it. It's where everything is housed, and it fights disease, it fights infection, and whatever we're incorporating or actually exposed to in our environment. When we think about, constipation, it's such a big umbrella term, and there's so many reasons and causes of constipation. How do you like to classify constipation, and how do you go about treating it, either through lifestyle such as fiber and water versus knowing when it is appropriate to use medications or different types of either prescriptions or over-the-counter meds?
Absolutely, yeah. No, it's a very, very common question. So, and the reason is because it's so common. So there is some statistics that said over 90% of the population in the United States is constipated. Over 90%. And as we talked about, it has to do a lot of it with our foods. And, over 90% of the patients who are constipated, and we'll have to define what constipation is. So before we can define the problem of constipation, let's define what it should be a bowel movement, how it should be a bowel movement. So the bowel movement or the defecation is the urge of emptying your bowel. So to have a perfectly normal bowel movement, first you find the urge of needing to go to the bathroom. Ideally, that urge happens at the same time every day. And we're going to talk about how to get there. So you, first of all, and it's so incredible that it will adjust to your schedule, believe it or not. So at that time, you feel the urge, you find an appropriate space for it. Obviously it will be your bathroom, or if depends where you are. And you sit down. The maximum amount of push or straining should be approximately 60 to 70% of your power. You should be able to empty within 5 minutes. And the stool has to be well formed, long tubes, well formed. And ideally, and it is another topic, is the hygiene, which I am completely against toilet paper. We can talk about toilet paper for another half an hour. But, the most hygienical way or best way to clean would be with water, and then, maybe with the wipe, and that's it. That's mainly the way to have a bowel movement. So now everything that is not like that is either diarrhea or constipation. So constipation it's the feeling of you trying to empty but being unable to do it. Okay, so then you still eat, you still go on in your life, and you still processing food, and you still putting that into your system and having like a reservoir or stool that at some point has to come out. Normally, if you look at the pictures of what constipation looks like, or a stool looks like, is normally little balls like this, round little ball, hard balls. If you have those 2 or 3 balls in your toilet, they sink down, you're in trouble. That's not good. That is, you're backed up. So we need to work on it. Especially if you do that every other day, every 3 days, that's not good. And diarrhea, on the other hand, if you go multiple times a day and you have is mainly liquidy, it's also problematic. Thankfully, the treatment for both is fiber again. And we can talk also about fiber, but in long story short, fiber, we need 30 grams a day. As an adult, we need 30 grams a day. So with the way you were asking me that I treat the patients with constipation when they walk into my office, we have a very long conversation talking that the majority is food related. Great majority of the time, 80-90% of it. So once we have documentation based on a diary of the patient that have tried at least for 3 to 4 weeks of a high fiber diet, we go into the next step. Okay, so fiber diet, you can do with the foods. You weigh like a cup of blueberries will give you 8 grams. A whole avocado will give you 9 grams. Chia seeds, blueberries, raspberries, and oats and fruits, vegetable salads. You can weigh them, you can measure them, and then if you're actually getting to 30 grams, it's hard to get to 30 grams. So you can also supplement with regular fibers, supplementation of fiber or gummies or anything, or bread or whatever you find also to supplement the need. So very rarely the patients continue to be constipated despite of this. Okay, so they were talking about a very small percentage, 10 to 15%. So then we look at 2 other things. We test blood work first. So before even blood work, medications. We talk about medications, and making sure we understand that still to this point I have not prescribed anything. Right? We're not giving any medication. We just said fiber. Now it didn't work. You're one of the 10 to 15% that we don't get better with changing your diet. Then we look into your medications. A lot of medications cause constipation. Especially for example, the new medication GLP-1, highly notorious to get constipation. So then you can make adjustments with it. If you're on a medication that it cannot be stopped and unfortunately gives you constipation, you might need to work with your primary doctor to find a medication like a stool softener to kind of even up. Not ideal, but sometimes we have to do that. If that is taken care of, the next step is blood work. So there's some hypercalcemia, there's thyroid hormone, vitamin D, that can cause also constipation. So make sure if you have hypothyroidism, just giving your thyroid replacement therapy will get you back in track, and as well as the hormonal therapy for female patients. And once that's taken care of, then we start doing other little more advanced tests. We can do a 6 marker study where you just have some 25 beats of radio pack with just an X-ray test that will see how everything is flowing. And then we can determine if this problem is because you have slow transit or is the problem with the pelvic floor. Some patients will need help with the transit. Some patients will need help with the pelvic floor. And we're talking about less than 2% of the patients about this. So we don't even need to go into details about that because it's so unusual. You really have to go through many steps to get there. And normally, we got to make sure if as I said at the beginning, all of these tests we do not start unless you're up to date on your colonoscopy. First thing, up to date colonoscopy, great. Let's start with fiber. Let's start with this. Let's start with labs. And then, we'll continue.
Right. I think that's so important because the fiber is going to be our, best friend when it comes to stools. And we'd love to know your favorite forms of fiber as a general question. But number two is knowing, some people are chronically constipated and they say, well, I've been like this all my life. I like one bowel movement every 3 days or one bowel movement once a week. Does the frequency matter? And when does it become alarming?
The frequency, some patients tell me, I have a really good, well done bowel movement 2 or 3 times a day. That's great. If I have a really well done large bowel movement once every 2 days, that's okay also. But if they have every 3 days, as I say, just small and not really, the best way I can describe is that you really have to feel satisfied with what you just did. It's like happy. I was like, oh, that was amazing. If it's like, if you struggled and you stayed there for a long time and you didn't really do a good work, that's a problem. So then it's when you start trying to address those issues. Then a lot of patients that have been normal for decades, I feel like they actually don't know what actually normal means. We talk about the connection between your brain and, patients who suffer with this can very easily be having difficulty sleeping, very easily having emotional or having anxiety or having depression or having skin issues or blood sugar or attention deficits. So that what we call normal might not be normal.
Right. Often I see patients with IBS or functional abdominal pain, and so they have all changes in their stool, and they've done their colonoscopies. They were up to really trying to figure out that gut-brain axis or dysfunction. And when you think about it, what would you recommend for that? Once again, water intake, because there people will say, I had so much fiber, but then I end up getting either still constipation or then sudden diarrhea. There's such a balance of the water and the fiber intake and also they take over the counter meds. What would you recommend to someone who's struggling, just to understand their sweet spot?
So water intake is very essential, and the easiest way to find out if you're well hydrated is just looking at the color of your urine. Well, normally, traditionally, we say there has to be at least 2 liters a day. Obviously, if you can just do those 2 liters a day of water, it's better than 2 liters away of stuff that it's not water, So that's the start of for the fiber, for patients who haven't really been exposed to the normal amount of fiber, it's difficult, the journey, starting off with 30 grams. Putting 30 grams to patients having them intake 30 grams of fiber on patients who's never been exposed to it will for sure give them bloatedness. They will feel uncomfortable, abdominal pain. It's just lack of appetite, feeling like they can't fit in their clothes, just very uncomfortable. And it's just because I tell the patients the good bacteria and the bad bacteria are trying to find their space, and the new microbiome is trying to grow, and then that's how kind of the pains of growing is happening. So you can slowly start going up. These will not work, as I said at the beginning. We have to wait at least 3 weeks, 3-4 weeks. So it's very important for the patients not to give up. Something very important into this, there's so many sources of fiber. So you have to be careful on specific what it gives you the discomfort, because, for example, in my personal experience, on my personal health, I used to have as quinoa a high source of fiber for me. I love quinoa. But suddenly, like 3 years ago, I started having belly pain. I was like, am I having too much fiber? What's going on? And it took me a little while for me to understand. I could not believe it, but it took me a while to understand that I developed an intolerance to quinoa. I don't have an allergy. It's not like I have a reaction to it. I just have abdominal pain, literally with quinoa. So our gut ages as well, like we all do. I tell my patients, if you ask me to have the same amount of Fruit Loops or candy that I used to have in Halloween when I was a kid, now I will for sure have diarrhea for 3 days. It's just too much. And my gut cannot handle that anymore. And with age, your diet also changes. So if we talk about, you have to have fiber, obviously, if you have some intolerance to certain things, that great, they have fiber, but also they will give you pain, don't do it. So for example, I stay away from the quinoa. I'm not going to do that. I like avocados, I like blueberries, I like chia seeds, I like oats, I like raspberries, I like fruits that have skin off, like apples. I like pears are amazing, cherries. I like my wife's salad. She makes an amazing salad, and she puts, I don't know if you have you had the palm tree heart? It's called heart of palm.
Oh, yeah. Oh,
So the heart of palm, she does in tiny little pieces and put it. So she does lettuce, heart of palm, cucumber, like the Persian cucumber, and the tomatoes, heart of palm, avocado, a lot of lime, mixes it nice, and and lettuce, and delicious. Oh my God. So she has definitely helped me on my natural way to get fiber. Before I tried all of the also fiber supplements, like there's Metamucil, there's Benefiber, there's psyllium husk. But, sometimes when my wife is out of town or something, I don't have the same technique of creating or patience to make the salad. So I have the spoon of fiber and try to keep it balanced.
I understand, and it's so beautiful because you can have that diversity of the fiber, if it's the greens or the chickpeas or finding the various tomatoes, and it comes to life. And I always like to say food first, as we know, and whole foods first, and that's really natural, and it has the antioxidants and the things that reduce inflammation. When we talk about other things, like people are scared of bloating often, either because of the stress or some type of, maybe they're in their cycle because of the estrogen and progesterone changes. And then other times, as it can be something they ate. How do you adjust bloating, and when is it abnormal, and is it a warning sign for anything? Because sometimes there is normal bloat. And going back to the fiber situation, and it's always good to change up your types of fiber, because sometimes protein powders will have various fibers and proteins that people might develop that sensitivity to, which I often see in clinic. So just back to the question is, how is bloating even develop? Like what's the physiological process there, and when is it normal, and when is it maybe something problematic?
Yeah, so as we talked about, the majority of the time, great majority of the time, the sensation of bloated or distension happens in the process of digesting the food. With age, as I said, our intestine changes, so it could really be a small little thing. Another issue that I started developing, and that one will give me bloatiness, is garlic. So a little bit of garlic will cause me to become like that. It wasn't that I had like a lot of food. It was just literally happened to be one. I know when I go out restaurants, everything is done with garlic. So I just prepared that I'll be bloated, even though you asked them to not do that much garlic for me. So if the bloatness is very closely associated with what you just had to eat, is the majority of the time benign, meaning it's not like a cancer or anything like that. It was just had to do with what you ate. And, with years, it becomes more common and common because you start having more intolerance to many other foods. So that's why it's really good to, as you were saying, expose to our body to different types of grains. Ideally, we should have 30 different types of greens a week, and that's how we create biodiversity inside on our flora. So that's a very, very important thing. Very rarely, very, very rarely, and that's some red flags. If you get bloated, it wasn't really associated with what you ate, and this discomfort causes you to have nausea and vomiting and fevers, chills, and it doesn't really get better. You're not passing the gas. You gotta go to the hospital. We could be talking about bowel obstruction, but again, that's very, very rare. Majority is just related with what we just talked about.
Right. Thank you for just laying out the process with that, because the next part is our, rectum and that area. And I know there's a lot of conditions that can happen there. And what do you often treat and see in your clinic in that area that may be under-recognized, under-treated, and maybe there's some new modalities for treatment in that region?
One of the most common referrals we get is rectal bleed. When the patient has an up-to-date colonoscopy and the rectal bleed is painless, so it doesn't hurt, it's just annoying because sometimes they clean and there's some blood there and it's just a surprise, it's related to hemorrhoids. So normally, if we go and talk about like changing the habits, not straining too long, no more than 70%, increase your diet, trying to have a nice, well-done bowel movement, it goes away. But there are some patients who still have the issue, like a prolapsing tissue coming out of the anus or still bleeding, despite them doing this or despite them having a regular bowel movement. Now, thankfully, we have treatment that can be done in the office. So back in the day, the only thing that was offered to patients was surgery. And hemorrhoidal surgery is defined as one of the most painful surgeries anyone can have. It's super painful. And the problem is that it's long painful, like weeks pain. Thankfully, now very rarely we have to do that. But even for patients who have to have a hemorrhoid surgery, we have modalities to decrease the pain. And normally that's explained to the patient, and it's a teamwork to decrease that amount of pain. But the majority of people don't need surgery. It's a very short office-based procedure, which is called the rubber band ligation or sclerotherapy. So basically, we take a look of those areas, the hemorrhoids, which have to be the internal hemorrhoids. We have two types: the internal that are inside, external is the ones that you can feel or some. The internals will put like a rubber band will go around the neck of the hemorrhoid, and during the next day or so will cut the circulation, it will shrink and it will fall off. It doesn't hurt because the internal hemorrhoids are in an area that there is no nerve endings for pain. There is nerve endings for sensation, so you will feel a sensation of something being there, like a sensation of you needing to have a bowel movement. Usually goes away within hours, but no further problem with that. Sometimes, on patients who are on blood thinners, we can't really do that. We have to inject what's called the sclerotherapy, and then they will shrink. Usually doesn't last as long as the rubber band ligation. Some other patients just had a history of constipation, straining, or pregnancy, and they have what we call a perianal skin tag. Out at the anus, there's something hanging out, especially young to adult females are uncomfortable. I don't like the way it looks. I don't like the way when I clean, it's uncomfortable. I just don't like it. Normally, we can also do in the office removal of the skin tag, some numbing medication. It very tolerable. No need for bigger surgery for that. We'll take care of it. And so those are the couple of the main things. Obviously, in-office procedures also has to do with what we do for abscesses or infections. Sometimes they need to be drained and stuff like that. So those are like in terms of the majority. And the other problem that we deal with is the pelvic floor and fecal incontinence as well.
Thank you. I think people don't often know that there are multiple ways to actually develop these internal external hemorrhoids. Maybe after years of straining, and you can let us how our hemorrhoids develop, because people wonder, they may think, well, I eat so much fiber, I'm healthy, I don't strain, but then they look in the colonoscopy, they find an internal or external hemorrhoid, and maybe it's not causing them symptoms, but when does it become a problem, and how can it be prevented, besides, I would say, fiber in water, which we talked about, but is there any other tools? Some people talk about pelvic floor therapy, doing those squats, certain exercises.
Yeah, so as we talked about, the hemorrhoids and are parts of our regular anatomy. You have them since the time you're born. And then it's all about pressure exchange. So the hemorrhoids are a cluster of veins, tiny, tiny little veins that are part of when our heart is pumping blood, it gets down there, and then it gets collected in those veins, and then the veins help the blood return back to the heart. If there is a lot of pressure in what we call the pelvic floor, and we have the two bones in our pelvis, and right in the center is what the rectum, if that is hanging and there's on top of it pressure towards down, then they start growing. When we're young, they grow, but they go back in. They shrink, they go back within minutes after you stop doing that. But it's multifactorial on how these ones will grow and actually stay long and big. And we talk about pressure. So pressure can be given by overweight, obesity, put the pressure down to the pelvis. Pressure could be given by pregnancy, baby pushing down. By the way, pregnancy, especially if you're younger ages, you will have issues with hemorrhoids. Is normal. It's normal. Everyone has them. The baby's weight is pushing down. You will have hemorrhoids. But thankfully, as humans, we have been blessed, and females have been blessed on it going back to normal after the baby is delivered. It doesn't happen immediately, but normally we don't even touch it. We don't even look at it for at least 6 months. 6 months, because the great majority goes back to normal. But that's how they are formed. So we talk about pressure of overweight. We talk about pressure of the baby, pressure of straining, pressure of pushing, pressure of erroneously doing their workout. So everyone on our workout is very good, as it has so many benefits of doing weight workout, right? It's in making our muscles or our strength workouts more as important as aerobic workout. Also, a weightlifting workout is very, very important. Now, everything that has to do with squatting or putting pressure to the pelvis will for sure develop or increase the risk of having hemorrhoids. So there is a secret towards it. The pressure should not be going down to the pelvis, to the rectum, should be going out to the abdominal wall. How do I do that? That's when we talk about straining your core, activating your core. So if you activate purposely, strain your abdominal wall and you lift, the pressure is absolutely not going to the rectum, it's going to the abdominal wall. In fact, Melissa, I had a patient who was like close to 70-year-old. He was a professional weightlifter, the one that they go up. And I don't know if you've seen TV, they jump and they have a huge belly, like they're like big guys and they have a big belly. So he came in for a screening colonoscopy, and I was like, he for sure has hemorrhoids, for sure. Like he's been lifting for 50 years. It's my head. So I examined him, and it was literally the most normal anal canal ever seen, like perfectly normal. So I asked him, I was like, sir, I was actually very surprised. This was at the beginning of my career. I'm very surprised you have a completely normal. He's like, of course. All my pressure is going to the core. I was like, what do you mean? He's like, have you seen us on TV when we're lifting and we have big belly? We are not fat. We have created the pressure towards the abdominal wall for so many, many, many years, straining our core that actually develops a little bump in our belly because we're putting everything towards the front. And that's why some patients, even some athletes using a belt to resist that pressure of the activating your core. And that's literally one of the best ways to prevent it. So now if you have to lift your groceries, if you have to lift your baby's cart, or you have to do weight training, activating your core will definitely prevent the hemorrhoids from appearing.
I love that. I think we've learned so much, just the physiological processes and how to avoid that, even because people love to work out and they don't realize that it's an important balance. And then you see people getting, inguinal hernias and abdominal hernias and like from the technique. And so now we can, have some good advice. Any other lifestyle, holistic measures that you just want to share today? I know that you're at City of Hope and it's very holistic there. I'm very impressed with the acupuncture, everything that you offer. So would love to hear your final thoughts.
No, thank you so much. Yes, I'm super, super excited to have joined this only cancer, specialty cancer hospital in Orange County. It's the first and only one. It was open in December of 2025. It has the utmost technology on it. And I'm super excited because we have been using the integrated medicine. So one of the things that attracted me, due to family reasons, my wife is from Los Angeles. I had to move for her work and for her studies to Southern California. And when I was looking to hospitals, what it really attracted me to City of Hope was the integrative medicine. So the majority of our patients offer all of this as a conjunction of their regular treatment. Now it's also very well known that for an advice to a patient, we normally have a multidisciplinary tumor board or multidisciplinary meetings, which we have the radiologist, the oncologist, the GI doctor, the surgeon, the pathologist, the meeting them and delivering the plan to the patient. But as I said, that's very common. A lot of hospitals have that. But as I always, my wife is a neuropsychologist, and she really made me start thinking about that part of the patient's psyche when someone is being told that have cancer. There is no patient, there is no person that will be okay with that. You could be the mayor, you could be the president, you can be anything, you could be a doctor, you can be a specialized person on that. No one is prepared for that news. So what the integrated medicine is, besides doing, what the gold standard is, having, the multidisciplinary, this hospital offers other things, and a lot of it is from the Eastern medicine, like yoga, massage therapy, music therapy, meditation, art therapy, stress management. They have the rehabilitation, the PMNR. There's supporting medicine, and one of my favorite part of the hospital. And Melissa, I want you to come. I will give you a personalized tour.
I totally want to go.
There is this called the multi-faith immerse spiritual care room. So basically, it's a room, and you can find it on their Instagram account, or it's a room that gives you an immersive experience of your personalized faith. So, for example, if you're Catholic, you go into the wall, you press church Catholic church, and the whole room will become like you are in the church. You select Judaism, Muslim, or if you are just a spiritual person who will just remove the spiritual. I do have to actually ask them to add the Baha'i faith, since I'm a Baha'i member. But it's incredible. So as people say, the place where prayers are said from your heart is usually the hospital, not the churches.
It's true.
Not the temples, is the hospital. That's when you really ask God for help.
Right. These life-threatening situations, these things that shake their world. And oftentimes that's why we created this podcast, because to us, there's so much fear that can come with any diagnosis, and sometimes a delay. And where's the hope in all of that, right? And where can we keep the endurance and get the support and know that there are people on your side and that really are rooting for you. And so I love your approach, Dr. Amir Esparza, and I love to hear more. I know I'll probably invite you again because there's so much to talk about and learn. And so where can they find you? Tell us a little bit more, either at City of Hope or if you have social media, wherever you would like.
Yes, we're here at City of Hope in Orange County. I'm not too active on Instagram. I'm trying to be a little more, but there is a Instagram account, Dr. Amir Esparza. I have also YouTube videos of some of the procedures that robotic procedures have done. So there's a YouTube channel. And, for professional sites, is the LinkedIn or the City of Hope official website. The professional Instagram account, normally I can, you can text, and I don't have a personal PR or anything, but I will answer and try to guide the doctors or the patients for sure.
Thank you so much. We'll share all
One
that.
day I have to be like you, Melissa. You're really good on the social media.
It's all fun, and we show our lifestyle cooking, and I'm sure we're all in this together. I saw your video.
I saw your videos. It's awesome. I like how you cook and the foods that you picked, and you're doing a good job. You're a great example for your patients for sure.
Thank you. It's hard work, it's commitment. I also had my own IBS and GERD, so I live it out. And we have to practice what we preach, walk the talk, and it's important. So thank you for doing the same. Thank you for being here. We'll see you again soon in person.
Thank you. No problem. Absolutely, Melissa. Have a great day, and thank you for inviting me.
My pleasure. Thanks so much. Thanks for listening to Autoimmune Alchemy. If you enjoyed this episode, please follow the show and leave a review. It helps more people find it. You can find resources and links in the show notes.